Hi, my name is Lydia Quella, and my IRB proposal title is Serum 25-hydroxyvitamin D Levels Effect on Weight Loss After Laparoscopic Sleeve Gastrectomy. My research question is, does sufficient serum 25-OHD levels prior to laparoscopic sleeve gastrectomy increase overall weight loss compared to individuals with insufficient serum 25-OHD levels prior to laparoscopic sleeve gastrectomy? My hypotheses are the null being individuals with sufficient serum 25-OHD levels prior to LSG compared to individuals with insufficient serum 25-OHD levels do not have increased total weight loss after surgery. That making the alternate individuals with sufficient serum 25-OHD levels prior to LSG compared to individuals with insufficient serum 25-OHD levels prior to surgery have increased total weight loss after surgery. So the goal is to examine serum 25-OHD levels in individuals who underwent LSG surgery prior to and after surgery and compare the total weight loss of patients who had sufficient serum 25-OHD levels greater than 30 versus patients who had insufficient serum 25-OHD levels between 21 and 29. The causal relationship between vitamin D deficiency and obesity are both still widely debated. However, many studies have linked a positive association between vitamin D deficiency and obesity. Results have indicated that the prevalence of vitamin D deficiency is evaluated and elevated in obese subjects, as well as an identified prediction between vitamin D deficiency with increased risk of the development of obesity. Further, in an analysis of 23 articles, all age groups were included with vitamin D deficiency. Results showed that independent of age group, obese individuals presented a 35% greater prevalence of vitamin D deficiency compared to eutrophic individuals. Other factors that influence serum 25-OHD concentrations include the amount of sunlight exposure, use of sunscreen, skin pigmentation, age, and dietary intake. In 2010, the recommended dietary allowance for vitamin D was increased from 400 to 600 IUs daily for most adults. However, this dosing regimen is still under debate, and the lack of consensus on the RDA adds to the confusion in vitamin D supplementation for the bariatric surgery population. I'm not going to go through this whole list of comorbid conditions related to obesity, but I wanted to show that this is a shockingly large list of medical problems that not only impacts the individual's health, but also increases healthcare costs to patients as well as employers and decreases productivity. Obesity rates have increased consistently and dramatically since 1970 in the United States and other developed countries. Identification and treatment rates for obesity remain low despite 1/3 of U.S. adults and children being obese. Racial minorities and ethnic groups are especially affected, with data being 76.6% of blacks and 80% of Mexican Americans classified as overweight or obese. Data shows detection and counseling rates among physicians remains low in the treatment of obesity, meaning a disruption between the need to provide obesity and the actual provision of care exists. However, data shows counseling rates remain low due to time restraints, lack of effective treatment options, insufficiency in training in weight management skills, or concern that raising the topic will be interpreted by the patient as insensitive. There are very few other medical conditions in society that are as stigmatized and shunned as obesity. Some of these health problems have the ability to be corrected or at least improved with effective weight loss. A meta-analysis which included over 22,000 patients showed bariatric surgery resulted in a mean loss of 61% and included substantial improvements in diabetes, hyperlipidemia, hypertension, as well as obstructive sleep apnea. Further, a reduction in the risk of premature death by 30 to 40%. Bariatric surgery is chosen in patients who have been unsuccessful in sustaining weight loss by non-surgical means. These days, the ability to sustain weight loss among people who suffer from severe obesity is not uncommon. The weight loss accomplished following bariatric surgery is highly variable, yet sufficient to accomplish improvement in medical and comorbidity control. The National Institutes of Health established a criterion for surgical intervention in 1991. Bariatric surgery is considered appropriate with a BMI greater than 40 and for patients with a BMI 35 to 40 with associated comorbid conditions, as well as failure of other medical therapies. Candidates for bariatric surgery must be assessed for appropriate surgical risk, including cardiovascular and pulmonary systems, as well as other system disease and control of comorbid circumstances. Physiological assessment is commonly done preoperatively to identify patients for major depression, binge eating disorder, and substance abuse that may impact the decision to proceed with surgery. Further, psychological assessment may aid in predicting postoperative weight loss. The LSG procedure eliminates roughly 80% of the body of the stomach, creating a tubular stomach, and is one of the most commonly used bariatric surgeries today. Vitamin D deficiency is common following bariatric surgery despite routine supplementation. The postoperative recommendations from the American Society for Metabolic and Bariatric Surgery include supplementation of 3,000 IUs of vitamin D3 and between 1,200 to 1,500 milligrams of calcium citrate per day. It is also important to note LSG complications are leaks of 0.5%, bleeds at 1%, pulmonary embolisms 0.5%, and strictures 3 to 4%. A meta-analysis by Shaktura et al. Describes the causes of vitamin D deficiency after bariatric surgery as being multifactorial. In addition to altered vitamin D metabolism preoperatively, poor adherence to diet and supplementation recommendations, as well as the types of dosage forms administered following surgery, fat malabsorption resulting from biliopancreatic diversion, and further reduced vitamin D intake from diet. Vomiting and decreased time available for food digestion, as well as bacterial overgrowth, also result in absorption problems. Bariatric surgery is associated with decreased bone mass and increased fracture risk, which highlights the importance of vitamin D in this population. The frequency of hypovitaminosis D in obese patients undergoing bariatric surgery widely varies between studies conducted in Western populations, ranging from 13 to 92%. For my study, recruitment, subjects are to be recruited locally from Baylor Scott and White Hospital satellite facilities in the Dallas-Fort Worth area, which offer bariatric surgery. Selection and participation will be a rolling period due to individuals having surgery completed at different times. Eligible subjects are men and women between the ages of 18 and 65 years old with a BMI greater than 40 or had obesity-related comorbidities and a BMI greater than or equal to 35. Related comorbid conditions caused by obesity include type 2 diabetes, high cholesterol, high blood pressure, heart disease, stroke, sleep apnea, asthma, arthritis, joint disease, reflux disease, and heartburn. Another inclusion criteria is serum 25-OHD levels between 21 and 30. Subjects will be excluded if they have hypercalcemia, renal sufficiency, hepatic disease malabsorption, history of medical conditions that require daily calcium supplementation or antacid use, or use of medications known to alter bone metabolism, specifically glucocorticosteroids and biphosphates. Further, individuals taking any medications that are known to alter or interact with vitamin D or with hypersensitivity to ergocalciferol or cholecalciferol are to be excluded. Subjects are to be split into two groups based on their 25-hydroxyvitamin D level preoperatively. Although there is no agreement on the optimal level of serum 25-OHD, most experts consider a 25-OHD level of less than 20 to be deficient. And it should be noted, vitamin D intoxication is observed when serum levels of 25-OHD is greater than 150. For our group of insufficiency, it will be considered 21 to 29, whereas a level of 30 or greater is considered sufficient. Group 1 will be individuals with insufficient levels between 21 to 29, and Group 2 will be 25 OHD levels sufficient with greater than 30. To verify the sample size, G-Power software was used. Accounting for attrition 30% due to the length of the study, 226 total or 113 participants in each group is necessary for a 95% confidence interval with an error of 0.05. Participants will fill out a standard questionnaire tool that is designed to elicit information about the amount of sunlight exposure received in a typical week, the type of clothing worn, sunscreen use, recent travel and season, outdoor activities, and work habits will be included. A study that evaluated weight loss after LSG concluded maximum weight loss at 24 to 36 months. To see if there is a correlation between weight loss and vitamin D levels, follow-up appointments for laboratory values will be scheduled preoperatively, postoperatively, and at 3, 12, 24, and 36 months. Weight loss will be monitored by BMI and waist circumference during follow-ups. Daily supplementation will be given of multivitamin, calcium citrate between 1,200 and 2,000 milligrams, as well as vitamin D in 1,000 IUs, and the vitamin D should be taken with the calcium, as well as a vitamin B12 in 500 micrograms daily in a tablet or sublingual form. Participants will receive informed consent, which will provide information about the study and voluntary consent to participate. The probability of harm occurring while participating in this research study is minimal. The risks from the research will be getting blood drawn 6 times throughout the study. With blood draws, infection and receiving a hematoma are both possible. However, safety measures will be in place. The proposed study is a quantitative experimental design. A statistician will complete a statistical testing once data collection is completed using a G-Power software. For comparison between groups, an ANOVA test will be applied. For all statistical tests, a p-value less than 0.05 will be considered significant. Data will be collected each study visit from all participants, and an evaluation of chi-square test will be conducted to analyze significant level of data and will be two-tailed. The statistical test will indicate if sufficient serum 25 OHD levels greater than 30 prior to LSG surgery produce more weight loss than insufficient serum 25 OHD levels between 21 to 29 prior to surgery. Due to the study being new, as this topic has never been researched before, it is difficult to have a well-rounded expectation of results based on the current literature. However, this research will attempt to fill a gap in knowledge of serum 25 OHD levels and the effects on weight loss. This study will be used to expand information of vitamin D insufficiency among obese population and determine potential treatment options. Further, implications of vitamin D deficiency have major risk factors on health and may be prevented with results of the study. There are limitations to the study design, including a lack of wide variation of vitamin D intake or supplementation, potential inaccuracies in the methodology used to assess dietary intakes and sunlight exposure, as well as participants to follow the supplementation and food guidelines being self-reported. Further, the sample size may not be fully representative of a larger population as well as be diverse enough due to the eligibility requirements. And here are my references. Thank you.